has population health and public health practitioner under his belt. He's a researcher and educator. He has also authored and pre-reviewed reviewed research publications, book chapters, and he's also been involved nationally with different conferences and roundtables and panel discussions. So we're very glad that he is willing to join us as well. And last but not least, he also works for Montgomery County Department of Health and Human Services. So welcome and thank you very much, Dr. Rogers, for your willingness to join us today. Some things I'm going to be winging because I've had a little bit of difficulty, so please bear with me. Today, we are going to talk a little bit about COVID-19, racism, and 3 key influences, factors in the African-American community, in addition to care planning decision-making. So I'm going to go right into the objectives. And today, the objectives that we're going to be talking about we're going to be looking at the impact of COVID-19 and racism as it relates to disparities in healthcare and societal life for African-Americans. It's going to be explained to us 3 key factors that often influence African-American healthcare decision-making and end-of-life planning. And lastly, we will be discussing how we might improve advanced care planning conversations among African-Americans to ensure goals of care at end of life, especially during this time of the pandemic. So right now, we're going to roll right into some of the data. So Gloria, if you would share with us some data that you've been able to pull up for us regarding COVID-19 and with nationwide with African Americans, that'd be great.
Muted.
Mute, unmute. You're muted.
Now, can you hear me?
Yes.
Okay. All right. Yeah. Thanks, everyone. Good afternoon. I'd like to start with just a brief look over some of the current statistics on COVID. You're probably also already aware of the news reports that are showing that African Americans are experiencing the highest rate of death in states that are reporting their racial and ethnic identities. The disproportionate number, those are causing quite an alarm right now, especially when we look at the fact that Blacks make up only about 13% of the total U.S. population, but are really accounting for nearly 30% of total deaths in some states. African Americans are being impacted more than any other ethnic group in the U.S. and are dying 2.5 times the rate of whites. Racial disparities and chronic medical conditions are also contributing to the increased risk of COVID-19 to people of color.
Thank you, Gloria, for that information. Dr. Rogers, would you like to elaborate a little bit on that? Do you have any?
Yes. Good afternoon. Just want to make sure you can hear me first.
Yes.
Yes, we can.
Good. Thank you. So yes, in Montgomery County, on March 5th, there was a public announcement of the first 3 positive cases of COVID-19 in Maryland, which was a couple in their 70s and a woman in her 50s. These were all residents who live in Montgomery County and contracted the coronavirus at a cruise. So the county, we've been responding to the coronavirus pandemic over the past several months, and when tracked Montgomery County's 3-day and 14-day averages, the county continues to show declines in core COVID-19 criteria and conditions that we monitor and measure to show progress in responding to the pandemic. To date, there have been 16,056 total cases in Montgomery County. There's a total of 725 deaths. It is important to note within the context of this webinar that non-Hispanic Blacks death rate is 86.8 per 100,000 or 160 deaths in the county. Now, the county continues to respond to COVID-19. Our COVID-19 testing in Montgomery County we've had a 6.4% testing capacity over the last 30 days. And with a 3-day average of about 3,621 tests administered. And to date in Montgomery County, we have tested over 112,000 residents, which is almost 13% of our county's population. I'll tell you a little bit briefly about how we are testing and supporting, because it's important to note when we talk about the African American community. Our testing and human services support plan places an increased emphasis on racial and ethnic disparities of COVID-19. We are prioritizing communities of color and zip codes at greatest risk. We have 3 testing tracks. We are testing our government employees. We are testing in our clinical and congregate settings, and then we're also testing in the community. Now, the community track is important because it includes strategies for which we outreach into African American communities, such as partnering with community agencies and other key stakeholders that we serve. And then we also conduct contact tracing. We partner with key organizations within African American communities in order to do outreach and contact tracing to identify cases so that we can better contain the spread of the disease. And then lastly, I'll mention that social determinants of health are important. You know, minority groups, African Americans, we suffer severely with high rates of social needs. And so in Montgomery County, we have what we call an integrated human services support, where we are at each of our testing events, we are identifying and addressing social terms of health to support communities at high risk. With that, I'll turn it back over to you.
Thank you, Dr. Rogers. That's really good information to know that the great work that's going on in Montgomery County, especially for the African American community. That's great. I'm just going to speak a little bit about Prince George's, and I don't have the type of statistics that you have, but I was reading an article, and this is according to the Baltimore Sun and some of the things that's been going on in Prince George's County that we want to talk about in Target. And I'm sure some things have been that they're working on some of the same things that we're working on in Montgomery County. But from the Baltimore Sun, 64% of Prince George's residents are Black, and more than 19,000 Prince George's residents have tested positive for the coronavirus. That's more than 27% of Maryland's total cases. And Prince George's accounts for 15% of the state population, yet more than 650 residents have died of COVID-19, which is accounting for 1/5 of the state's total deaths, coming in second to Montgomery County here in the state of Maryland. And some of the other things that we have to contend with is that churches and funeral homes and community organizations are scrambling to provide food and comfort as losses are mounting. Loss of not only people and their loved ones who are dying of the virus, but for the loss of jobs, income regarding this pandemic. So not only are we having to address the situations of the disease itself in the African American community, we're still contending with other major issues, underlying issues that with certain systems that has always been in place that we're contending with as well. So having said that, we have a lot of work to do, and we have a lot of coming together to do to not only fight this disease, but also help with helping and lifting one another up in our community. Mm-hmm. So moving on to the next one, Ms. Gloria. Can you share a little bit with us why African Americans are more susceptible to hospitalization and death due to COVID-19?
Sure, yes. Most of you probably have heard a lot about the underlying health conditions, the pre-existing health conditions that are listed here on the slide are some of those, obesity, asthma, high blood pressure, etc. But according to a recent article in Science News, there are other contributing factors to being more vulnerable to this virus, one of which is the type of occupations that many Black and brown people have. Many of them work in frontline service positions such as healthcare workers, grocery store clerks, restaurants, public transportation workers, and so on. And these essential frontline jobs force them to be out in the general public, and they cannot always adhere to the social distancing requirements or shelter-in-place mandates. Another critical reason is that many of these positions don't come with health benefits through their employers, so being uninsured presents yet another barrier to healthcare access and affordable medical care. And so I hope this is helping us to understand better that just having the pre-existing health conditions or the comorbidities that are mentioned, that's only a fraction, a tiny fraction of the real cause of why COVID is impacting African Americans and Hispanics disproportionately.
I agree. In addition to a lot of frontline workers, it's just that frontline workers, it's a must, you know, having to support their families. There's no getting around being able to take a leave of absence or working from home because they're serving the public. So having said that, the frontline workers, we need to give them a shout out for sure. I think America has seen the impact of frontline workers and how they really need to be supported.
Amen. Yes.
And now let's talk a little bit about the impact of racism and its underlying roots and causes.
Yeah, thanks, Terry. First, it's important to know that health disparities toward Black people is not anything new. It's been going on for 400 plus years since the onset of slavery, where horrendous medical experiments were done on Africans who were on slave ships coming to Virginia. So the real root cause of disparaging treatment, though, is one that most folks don't want to talk about or think about, almost like end-of-life conversations in a way, and that's racism. Racism on the individual, on the institutional, and on the cultural levels. And just a definition of racism for the record, it's prejudice, discrimination, or antagonism directed against someone of a different race based on the belief that one's own race is superior.
Now, Gloria, I have a question. Some people think that everybody can be racist. Is that true, or what is your take on that? I've heard a lot of different answers to that question, but give us your input on that.
Sure. Yeah, I say that it's not true. All of us can have prejudice, though. We have preconceived notions. That's part of our human nature to do that, but not everyone is racist. And racism is really a power thing. So racism is applicable to those who have the power to oppress others. And so that's the difference. So, you know, I can't be a racist. I don't have power to oppress any people group.
Okay, thank you.
One other thing I just want to say, if you don't mind, I was just thinking.
No, not at all.
You know, many white people, I've gotten calls. I have lots of white, you know, colleagues, friends, you know, people all over because of the work that I do. And white people who want to be allies must understand that Blacks are not victims of their inability to do for themselves, but they are victims to the systemic oppression that's imposed on us by those systems that are in place.
Thank you for that, Gloria. Let's talk a little bit about the current look at disparities now.
Sure, yeah. We can see how that historical background plays out in the 21st century, where Blacks still experience the poorest quality of living as compared to whites. For example, Black Americans are more than twice as likely as whites or Asian Americans to live in poverty. Infant mortality for Blacks is more than twice that of whites, and the unemployment rate is twice that of whites. Black Americans have also have the highest death rate and have the shortest survival of any racial or ethnic group in the U.S. for almost all cancers.
Wow, that is the particular, and then put that on top of the pandemic.
Yeah, oh gosh, yes.
Yes, yes.
We're seeing a lot of fallout from all of that at once, and that's what we're seeing surface in the media, and most people are becoming aware, what we call woke, to some of these systemic issues that are I guess they're just amplified, if you will, due to COVID.
Thank you for that. Dr. Rogers, did you want to say anything regarding this slide?
Well, I mean, this is a conversation that we have been talking about for decades in public health, right? Health disparities, right? Social determinants of health, right? The poverty, unemployment rates, life expectancy, infant mortality in African American communities. And like Gloria has mentioned, you know, people have become woke, but it's nothing new to us public health professionals and us African Americans who are actually living this day to day. And so the pandemic has just exacerbated the need for more resources within the community, within our organizations, to begin to really, truly address these disparities so that, God forbid, the next pandemic comes, we won't still be having the same conversation.
Yes.
I totally agree. I totally agree. Thank you. Thank you for that input. Now we're going to discuss the key factors of influence in African American decision making in healthcare and end-of-life planning. Gloria, if you would start out by sharing some of these historical insights for us.
Sure, absolutely. These are just 3 areas. Of course, there are many more areas that we could, look at in terms of what that is. But those 3, historical mistrust and racism, the cultural, generational values, and spiritual and religious beliefs, those were part of what my research uncovered. So that's why I'm focusing on those. And so when we look at the first key factor is historical mistrust. Research shows that there is a difference in medical care between Blacks and non-Blacks. The Tuskegee syphilis study is a major one that many people know about. That was when Black men were, they had syphilis, but were told they had bad blood, and the public health department had penicillin available to give them, but did not give them that because they wanted to see the progression of the disease. So that was an unethical one that many people know about, but there are many others that are not as well documented. One is through medical apartheid, through Harriet Washington's book. She lists all of that historically if anyone wants to know. But these other factors are important. And so I want to point out that Blacks often report that medical professionals take their ailments less seriously when they do seek treatment, which speaks to the mistrust issues that many people of color have when it comes to receiving equitable health care. I also want to mention the misconception of African Americans having a high tolerance of pain, which is another fallacy. A study that was published in the Proceedings of the National Academies of Science found that 40% of their first and second year medical students, which medical trainees, believe that Black people have thicker skin or less sensitive nerve endings than white people. So, if our students, medical students, are having those kinds of false perceptions about Blacks, then that's another whole area that needs to be dealt with in terms of the educational process and learning that, no, we don't have a higher tolerance of pain than anybody else.
Thank you for sharing. Would you like to comment on that too, Dr. Rogers? If not, we can move to the next slide.
Yes, thank you. I think it's important to mention that African Americans continue to be underrepresented in clinical trials. One reason being mistrust of the medical system. I mean, in many cases, African Americans may not see that the study staff are genuinely committed and concerned about their well-being. I mean, additionally, the pervasive structural racism of our society, as communicated in the Tuskegee syphilis study, has underscored the shameful history and unethical experimentation on Blacks. So this raises concerns for the efficacy of the COVID-19 vaccine clinical trials, right? So vaccine trials, they should include participants from communities that have the highest risk of infection. And so given the data that we previously discussed, African Americans, and I also must mention Hispanics and Latinos for that matter, are essential populations to have as part of the COVID-19 vaccine trials. Before they are willing to join clinical trials, we as healthcare community, we have a responsibility to continue working aggressively to break down these barriers so that more African Americans are willing to participate and, for example, COVID-19 vaccine clinical trials.
Mm-hmm.
Yeah, that's a great, we talk about that a lot too in the way of the different trials. And I'm not a medical doctor, but I've always wondered myself, when we don't participate in medical trials, how well is the medicine for African Americans if we're not in those trials? How the meds will react to us if it's not built up with our DNA. So that's always the question that I've always had personally. Thank you, Dr. Rogers and Gloria.
You're welcome. Yeah, this slide, we added because I thought it was really important as we talk about health outcomes for African Americans. There were two times, according to Dr. Rodney Hood, that 2 times in history that provided better health outcomes for African Americans. The first time was after the 13th Amendment to the U.S. Constitution, the emancipation of Black slaves in December of 1865. And that was through the Reconstruction years, where the Freedmen's Bureau was initiated by the federal government. And this is where Blacks helped themselves. They built their own hospitals and schools and served the needs of their families and community. The second time in history was during the Civil Rights Movement in the 1960s and the momentary opening of the middle class that opened up in America, where many African Americans were able to gain access to some of the resources and opportunities predominantly restricted to white Americans.
Thank you for that bit of information, Gloria. That is great. And I'd like to pause right here just for a minute, because all of the things that African Americans have gone through and our history and everything, I have to point out the picture of John Lewis that's in the slide right now. And Gloria, we've been working on this for at least the last 3 weeks or better, and the picture was already there. It just happened to be there. And if it wasn't for our forefathers doing just what they're doing in that picture, marching and trying to get better health care and housing and all those types of things, the picture that you used, Gloria, kudos to you for that. Thank you.
And we do honor John Lewis, too, and his legacy, because he has been very instrumental into us being even at this point. And so his loss is for all of us, and we mourn his loss.
And it's important to mention that John Lewis was on the front lines as the Affordable Care Act moved through Congress, right? And so the Affordable Care Act takes strides in addressing many of the health disparities that African Americans and minority groups are experiencing today. So I also wanted to point that out as we're talking about health disparities. Rest in peace, Congressman Lewis. That he was there working along in the House with President Obama to be a leader, a voice during that time.
Yes. And in the work that we're doing right now, we have to say that we're hard shoes to fill, but even in this setting right now, we're going to keep pushing forward to do that what we have to do. And we would also be remiss, because I have to be honest, since we're talking about history, I've never heard of the name C.T. Vivian, who had worked since the 40s with Jim, doing the inside of Jim Crow laws all that time. So kudos to him as well. And from my understanding, we lost a total of 3 very significant people in the African American community in the last 100 days. And that third person, rest in peace, but I'm not sure of the name, but that is significant to have that type of loss in our community within a 100-day period.
Yeah. Now, I just want to share some of the Southern-based cultural values that many African Americans rely on that influence our healthcare decision-making. First, just the whole need of having family relationships. There's a very high value on friends and non-family relationships, and that's known as fictive kin, and that's where non-blood related people are referred to as my aunt or my uncle, my play mama, cousin, those kinds of affectionate terms. They're not really related, but they're close relationally. one thing I want to point out here is that African Americans are more collectivist in their approach to life rather than individualistic, which is where the whole family, the fictive kin, the church members, the family members, the friends, all kind of participate in decision-making processes. So it's not just what I want or think as an individual, it's what all of us think together would be best. And so, like most other cultural groups, family heritage, traditions, and belief systems are passed down generationally. However, fragmentation of these cultural values has happened in our communities, mostly due to the effects of poverty, here again, drugs and mobility. Many family members don't live close to each other anymore. They live apart due to personal choice or jobs, economic reasons, even divorce and marriage and those types of factors. But that's really, I wanted to just point that out in terms of, oh, I think we're on the slide before it. Which one are we on? Yeah. So that's the second way, but that's fine. That's fine. I wanted to talk about that.
The spirituality piece? Well, I'm not sure if I got ahead of you,
Oh,
so
yeah,
I
I think you got
apologize.
ahead of me. That's okay. We didn't talk about that one, but that's okay. I talked about the family one. That was the one that didn't show, but that's okay. I can say a few things about this as well because this is, I think, really important in terms of the generational and family values too. I share a couple of stories, true stories, examples to kind of show the sacrificing of one needs in the family-directed care. A daughter that I know in one of the cases was taking care of her mother with Alzheimer's, and her mother had other debilitative health issues, but she actually retired from her job and actually dedicated her life to taking care of her mother for over 15 years. And she said to me one day, "Mama was always there for us." So that shows that type of sacrificing one's own needs. Another situation was a daughter-in-law who not only took care of her sick parent, her husband's sick parent for over 10 years, but her husband who was also ill. And she also said that it was her sacrifice to care for her loved ones. So when we think about the relying on spirituality and faith and the relief from physical, and go back one, Terry, go back to that one. Yeah, that one right there. Because I do want to share this too around that whole value of spirituality and faith and focusing on life rather than death. A very close family had a situation happen where one of their family members was involved in a car accident and was left brain dead. The doctors had given the prognosis, and few of the family members kind of accepted that and wanted to remove the life supports from her because they said that she needs to, let her go on and be with the Lord. That's a terminology that many African Americans use to say, let her die in peace. And the majority of the family, however, felt that that was wrong to remove those life supports because they felt that they would just wait and pray that God would do a miracle for her and that their loved one would be healed by a miracle. And so I wanted to point this story out because this is one of the reasons why advanced care planning is so important to talk about. And we'll get to it a little bit later, but I do want to say that that is a value that has sometimes caused some of the confusion that I've seen in families because the decision hasn't been made or the person didn't get to make a choice about what their wishes were.
Yeah, very much so. And it stops a lot of confusion and tension with families and things like that. It may not be the easiest topic to talk about, but once you have some guidelines to go by, that makes it so much more easier for the family, and it puts the person who's needed to do that at ease. Dr. Rogers, would you like to comment on anything that we're discussing right now?
I mean, yeah, and we'll probably talk about it a little bit more, but I think that for many African Americans that, even though we have the faith to believe, it's still important for us to put the advanced care planning things in place because, evidently we will all pass away someday.
Yeah, absolutely. Thank you. Thank you for that.
And so the third key factor that I just wanted to bring up in this presentation is one that's very important, and that is the spirituality factor. Pew Research shows a ratio of 1 out of 2 African Americans believe in a higher power, commonly referred to as the Creator or God. Religion, particularly Christianity, has played a major role in African American history. While most Africans brought to the New World were slaves, they were not Christians when they arrived, but many of them and their descendants embraced Christianity, finding comfort in the biblical message of spiritual equality and deliverance. So the church continues to be a key entity in the lives of many African Americans for their social and psychological and spiritual care. And because of African Americans' unique cultural history and value system, the decision-making process regarding life issues often are impacted by our spiritual and religious influences.
Yes. Would you like to comment, Dr. Rogers?
I mean, you know, as a licensed and ordained minister myself, I kind of know this issue very well. And we talked about structural racism earlier. And Gloria just mentioned how the church, you know, has been involved, you know, in the spirituality of African Americans. Well, the church history tells us that has a role to play in creating structural racism by many slave owners utilizing the Bible as a tool to have African Americans believe that their oppression was biblical. So, exactly. You know, which is, we can have a whole webinar just on that particular topic.
Yes, we could.
Right? But so I'll kind of leave it there.
Yeah. Right. And when you talk about that, I just remember watching or knowing the history of Nat Turner, because they were trying to get him to have that same type of concept until he realized himself, or really knew better, that's not the case. Thank you for that comment.
Yeah. Okay. So yes, that's fine.
Okay. And Gloria, if you can share with us now some recurrent themes in African American spiritual beliefs.
Sure. Yes. So these are some of the recurrent themes that I found in the literature. Spiritual beliefs are often a source of comfort, coping, and support to many Black families in everyday living. Also, researchers agree that religion and spiritual belief have been attributes to influencing the treatment preferences African Americans have in the face of illness. And with many African Americans, they resort back to those early religious and cultural beliefs at the end of their lives, too. So some also see God as being responsible for the physical and spiritual healing, as well as seeing God use the doctors as an instrument for that process.
Okay, thank you. Dr. Rogers?
Well, I guess I'll probably say two things. One is, you know, as Gloria just emphasized, African Americans overwhelmingly believe in God. So, you know, one would assume that what flows from that, you know, is a belief that God is a healer. Right? Yet, even with great faith in God for healing, when faced with a near-death experience, one must use wisdom, right, by taking the proper advanced planning steps. Because as I mentioned earlier, we all will eventually die one day from something. Now, it may not be health related. You know, it could be like Moses, who just died of old age, right? So we must be mindful of that care planning.
Yes, and thank you for that, Dr. Rogers. And I think one of the most important things as we keep navigating through these slides is to be able to bring to the community how to go about filling out, you know, the advanced care planning, making it very easy to be able to do, make them comfortable in knowing that making these plans is the best thing that they could ever do, and making sure that it's not so cumbersome to get through. And that is our job, especially at Montgomery Hospice with our social workers, Gloria, you may want to speak a little bit as to some of the work that you've done with the faith-based communities through that we both played a part in when it came to surveys to find out what members are looking for from their pastors and the different heads of the different ministry, like the cancer ministry and things like that. So as long as we continue in the community to educate the community on advanced care planning, maybe not so much in a setting where it's almost too late or there's no choice or because they have a diagnosis, to get that out early is very important.
Right. Well, one of the things that we've been working on for several years, maybe 5 or 6 years, in fact, is working together to educate or bring the resource. And one of the resources I created is the African American Guide, which is meant and was written for African Americans. It's a culturally centered piece that actually tells you all that you need to know about advanced care planning and to have a conversation. And so that product is available along with a training program that I just created last year based on a survey I did with 72 pastors, faith leaders who told me what their needs were in terms of having a tool that they could use to help their congregants in times of this, making those decisions. So we've got that too, and it's available on our website. Information about that is at eolcareguide.org. And then we can probably put it in the chat too, if you'd like to just look at that and contact me off this platform for more information.
And what's going to be good about that is once we do the, in the booklet that we're partnering with you on, once we brand everything, it will be conducive to the state of Maryland, the paperwork to fill out with that. I'm sorry, Dr. Rogers, you wanted to say something?
Yeah, I just wanted to add that based on the previous slide, why it's important to acknowledge that overwhelmingly there are a number of African Americans who believe in God, right? Black church attendance is dropping across many congregations, right?
Yes, it is.
The age of the congregation is skewed heavily towards people 60 and over, right? Mm-hmm. But nevertheless, the church continues to be a cornerstone and key figure in the African American community. Yes. And so church leaders such as pastors, ministers, deacons, deaconess, and health ministries, for example, they continue to be well respected in the community, even among those who do not attend church regularly, right? So it remains essential to engage African American houses of worship in conversations around advanced care planning and decision making. I just wanted to add that.
Yes,
absolutely. And so I'm glad you said that, because that shares with us that we're on the right track. Thank you. Thank you. So now we're going to move on to the next slide and have a little bit of community dialogue discussion. To the audience, how can we improve advanced care planning conversations among African Americans to ensue end-of-life care, especially during a pandemic? Gloria, I'll start with you.
Well, the slide before that, there was one that says why there's an urgent need. I like to kind of speak on that.
Okay, I can go back.
And then I can go, just go back that one right there. I think that's really important in order to be prepared to have that conversation and to talk about that, because individuals and their families who are at the highest risk for complications from COVID, they're very vulnerable right now. No one knows who will get sick, how sick they will become, whether they would want to be in a hospital or be on a ventilator. But there's a way that they can have some control by choosing their healthcare agent, of course, and by making their preferences known. So that's really important. The reason that this decision making is so critical is that if we don't make our decisions or make those decisions, then someone else will make those decisions for us, and it may not be what we want. So that's why I feel like it's very urgent for us to even talk about, and to us to encourage other people in our community to have that conversation and to make those plans, not because you're planning to die. None of us are planning to die, but like Dr. Rogers said, we all are going to die. It's part of the life cycle. And so that is why there's an urgent need. And so when you go to the next slide, which is the one on the question, the community dialogue question, here I would say many people don't want to talk about this. I mean, it's a hard topic, whether we know about it like in our profession or not. But healthcare systems should not be our custodial guardians, if you will, at the end of our life, or in cases of life-threatening illnesses that might happen or accidents. We should be in control of that. And so in light of all the information we've covered so far in this webinar, COVID-19 stats, racism, the uncertainty of it all, the 3 key factors that I talked about, all of those things, what do we do now in terms of conversating? How do we get people to talk about this need? And that is, because most people don't want to talk about death and dying, regardless of their ethnicity. It's not just Black people or Asian or Hispanic, it's all of us. Nobody really enjoys this conversation, but it's very important, especially now with COVID-19, and it's the invisibility of this disease and how it's striking so many people. I just got a call the other day from a writer who has just contracted this disease, and a writers group that I'm a part of. And so, 2 weeks ago, that was not the case. We were planning a training or whatever. And now that's, so this is something that I believe is very important to have these conversations. And so when you ask me what would I say the first step would be to just talk with the people you love. Talk with the people you love about what your wishes would be if you weren't able to speak for yourself. And it's so important also to have advocacy. Having someone there to speak for you, and also to help you process some of this information. Medical processes are very complicated. Navigating these systems can be challenging for the person who has a doctorate or for the person who has no education or not able to read. Sometimes it's just hard to get through. So it's best to have somebody there to advocate for you. I can speak from the experience I had in 2007 when I was misdiagnosed by a doctor who was physician biased. She based her decision on what was going on with me based on her own understanding of what Black people have, high blood pressure. She didn't do any further tests to see. And a year later into that, I wound up having a life-threatening illness that I almost died from. That is part of the reason why I stress the importance of advocacy and having someone else to speak for you when you can't speak for yourself. And I'm grateful. I was one of those that God did do a miracle. He did bring me back from the point of death, but I believe it's for this type of reason that I can still be a voice and speak around this issue to help others avoid those kinds of circumstances.
Thank you, Gloria. And I'd like to add on to that, and then I'm going to come to you, Dr. Rogers. I think that is the reason why when we're healthy, when we're not under stress, that we put things in order.
Yeah.
Dr. Rogers?
Well, I was just going to say that within the African-American community, when we talk about advanced care planning, estate planning, it comes with dollar signs, right? And so, which could be a reason why, one survey that I read, showed that, only 42% of U.S. adults currently have estate planning documents such as a will, living trust, healthcare power of attorney. And then when you look at the percentages for younger people and minority, they continue to significantly decline. And so I think that as we talk about targeting minorities, we need to target them with outreach and education, but in addition to free or low cost estate planning, advanced care planning resources, right?
Absolutely.
So we have to bring to their attention that, hey, you don't need a lawyer all the time to draft these documents, right? It may not cost $1,000. I mean, even me, myself, you know, my uncle recently passed away, and I saw firsthand the importance of appointing a specific individual, right, to make medical decisions if you're incapable of doing so, right? And you know, that doesn't cost a whole lot of money. And so we need to communicate that to African American communities, that there are free and low cost resources to help you with your advanced care planning steps or documents.
Yeah. Absolutely, absolutely. Thank you for that. Now we're going to take a poll. I'm going to ask Beza if we are able to do that.
Yes.
Today? Okay.
So the poll question is going to be actually going back to what Dr. Rogers just said, to gauge how many of you have completed your advanced directives or have had the conversation with a loved one. So I'm opening the poll right now. We're going to give you 30 seconds to a minute to go ahead and respond to that. Great, the responses are coming in. I'll be closing in about 30 seconds. Okay, and I am now sharing the poll results with you all.
Okay, let's see.
So we have, are you all able to see the responses?
Can you tell us what it is?
Yes, absolutely.
Okay, thank
so
you.
for the question about how many people have completed their advanced directives, we have 24 out of 72 people said yes, and 21 said no.
Okay.
27 did not respond. And then for the question about having a conversation with a loved one, 42 people said yes, they've had the conversation, and 3 said no. So there's a significant difference between those who actually have completed an official document versus those who've had the dialogue or have had the conversation regarding their end-of-life care or wishes.
Okay.
Okay.
Very interesting.
Very
Action
interesting.
steps. I guess what speaks for me there is action steps. Many of us are having a conversation, but we're not taking the next step to actually make it official. And until we have like a near-death experience, or, you know, I must be honest, even for myself, you know, with my uncle passing causes me to want to revisit and have that conversation more with my wife with regards to advanced care planning and making sure we have our documents in place.
Yes.
Absolutely. Absolutely.
Yes.
Okay. Thank you. And thanks for being able to.
Yeah, that was great. Thanks for participating in the poll. And I think the last, let's see, what's the next?
We're going to talk about the importance at the end of life.
Yeah, that's okay. So yeah, we want to encourage everyone to definitely have those conversations, and like Dr. Rogers say, take that second step after the conversation, actually complete those documents. But regardless of our culture, our ethnicity, class, or other human-created factors that divide people, all of us share the commonality of being born and dying. So what's really important at the end of life, most of us will probably agree, is not how much material wealth we've had, or our position, or our title. I remember when my children were in middle school and they formed this girls group called STAND. And there were about 10 girls in this group, and they decided to visit the nursing home in the town where we live once a month, taking cards and kind of making special holiday treats for them and talking with the residents. And I'll never forget the girls asking me why some of the people that they would talk to would be talking about all these special events in their lives, like when they swam hang on the porch with their family or friends, or the graduation that their child went through, or their, wedding, or memories of a loved one, and stories of love and all of that. Not one of those people spoke about their job or what they had accumulated in life. And so I see that's the gift that we give to our families when we complete advance directives and make our wishes known. For this is really no ordinary time, and I believe it calls for extraordinary measures. That begins with all of us, humanity, realizing that none of us are better than any of us, and that we all fare better when everyone's needs are met in a socially just society. It's a time to come together as the collective humanity that we are. And I believe that this pandemic is a wake-up call for all of humanity to get back to the basics of human dignity and worth and start living in harmony together, and more than anything, loving one another as we love ourselves. So.
Absolutely. Thank you, Gloria. Thank you so much. But thank you, everyone. And definitely thank you, Dr. Rogers, for participating with us today, and Gloria. And Beza, I'm going to ask you if you have anything else that you want to say to anybody. But I hope people got a lot out of this. And during the series that we're working on, we hope to have different guests and different people. But Gloria and I have been working together for a while on different series, especially during COVID, that for some people who, I think this is a good venue to talk about it in, that you will keep seeing a lot of Gloria, because we're working on a huge project that's going to go into 21 and into 22. So get familiar with her, because you will see her, but that also doesn't mean that we're not going to bring other panelists on as we did with Dr. Rogers today. Thank you again for your input, Dr. Rogers.
Yeah.
Thank you.
Beza?
Thank you all for this wonderful, wholesome presentation. I learned a lot. We are absolutely thrilled to be partnering with Montgomery County and Healthy Montgomery to continue the awareness, the education that we do in the county, both on advanced care planning, social justice issues, and so all of that matters, and education is our forte. I would encourage you to continue the conversation. Don't let the conversation end here. Take what you've learned today, share it with your colleagues, with your loved ones. With that said, I'm gonna send a follow-up with the PowerPoints, as I've mentioned earlier, as well as a link to an evaluation form. My colleague Meghna is also sharing a link to the electronic version of it. I ask you to take a minute to complete that evaluation. Your feedbacks are very important to us. They help us improve our programs. It also tells us what to focus on next. So take a moment to complete that. If you're not able to click on the link before we log out, you could also find the link in the email I sent this morning and as well as yesterday. This program does count as an elective towards the Montgomery Hospice Certificate in End of Life. So if you're a candidate, this is a program that would count towards your progress. If you're not familiar with the Certificate in End of Life, I will send more information on that. We're also sharing a link to the program in our chat box. With that said, thank you all for being here with us. I hope you enjoy the rest of your day. Bye, everyone.
Bye, everyone.
Thank you.
Bye-bye.